everyone. My name is Cary Cunningham. I'm the medical director at UCSF Citywide Division of Case Management. And I want to welcome you all to this morning's Department of Psychiatry and Behavioral Sciences Grand Rounds. I am thrilled to introduce this morning's speaker, Dr. Enrico Castillo, who will be presenting on the topic of structural awareness and structural action in homelessness. Dr. Castillo is a public psychiatrist with the Los Angeles County Department of Mental Health and an assistant professor in the UCLA Department of Psychiatry and Biobehavioral Sciences, Center for Social Medicine and Humanities. He's also the associate director of residency education at UCLA Semel Neuropsychiatric Institute and the faculty lead of UCLA Community and Global Psychiatry, a resident faculty collaborative focused on public service and health equity. Dr. Castillo's research is focused on community-public academic partnerships, the integration of mental health and social services, public mental health and homelessness and housing policies, and medical education on structural competency and health equity. His research has been conducted in close partnership with multiple local, state, and national agencies and community organizations, including the Office of the Surgeon General, the Los Angeles County Departments of Mental Health and Health Services, and the Healthy African American Families too. He is a current member of the APA Council for Minority Mental Health and Health Disparities, is a column editor for the Journal of Psychiatric Services, and serves on multiple editorial boards, including the Academic Psychiatry and Community Mental Health Journal. One note, please place your questions in the public chat, and we will begin the Q&A at about 9:20 a.m. So please join me in welcoming Dr. Castillo.
Hi, Dr. Cunningham. Thank you so much for the generous introduction. I really appreciate it. And, I just wanted to say that it's a huge honor for me to be invited to speak with you all today. I was reflecting and I just wanted to talk with you all before I launch into my slides, before giving my talk, which is focused on politics and policies. I think it's really important for me to recognize that this is a particularly terrifying moment in our nation's history, one where white supremacists and domestic terrorists are given free access to our nation's capital. Okay. I was born and raised in rural Southwestern Virginia. And I just want to share with you that, it's an area where it's not uncommon to see the Confederate flag. It's a symbol of hatred. And I'd see that flag posted in front of people's houses when I was growing up. And to see it, for me, brought into the nation's capital for maybe the first time in history, that was something that was very traumatizing to me. And I know that day last week landed differently for different people. So I just want us to recognize that. So in my talk today, I want to make it clear that the racism and the injustices that we see on the news are widespread. They affect our patients, they affect our everyday work, and they affect our institutions as well. But on a lighter note, I just want to say that during this time, I hope that you all are practicing self-care, that you all are reaching out to loved ones, friends, trusted colleagues. And so for me, this is a part of that, this Grand Rounds in particular. And I'm so glad to be connected with you all in this way, particularly because I feel such a strong connection with your department and mentors and colleagues there. And then before I also start, I just want to express my gratitude to the LA County Department of Mental Health and to all of my mentors and residents here at UCLA as well. And there's too many for me to name. But particularly, I wanted to thank our whole team at the Center for Social Medicine and Humanities, and in particular, my mentor, Joel Braslow, and our group in Community and Global Psychiatry. So thank you again for having me today. So I'll share with you my screen. Okay. So my talk is titled, We Must Dissent, Structural Awareness and Structural Action in Homelessness. And as the talk goes on, I'll be sure to explain, what the title means. My aim in this talk isn't to give the final word on homelessness. It's just such a big topic, so that would be impossible. But I want to tell it a little bit through my lens. And, my research in our center, it focuses on health equity, focuses on examining public mental health policies and systems to understand how they either address inequities or inadvertently make them worse. And so I want to share with you all how my clinical experiences as a public psychiatrist and also my research have shaped just a lot of things for me. The way that I view my role as a physician, my views on homelessness, and also the ways that I try to teach our residents. So here are my disclosures. I'll just let that show there for a second. And I don't have any conflicts of interest. So I was hoping that we could begin with just a brief reflection exercise, just a couple of minutes. I just wanted to make sure that when we're talking about homelessness, we're not talking theoretically, but we're talking about people. So if you could, you could either do this mentally, you can jot this down on your phone or on a piece of paper, but try to think of the last person who you treated who was experiencing homelessness. And name 1 or 3 things that you wished you could have done for them. And also, what were some barriers that prevented you from doing some of those things? I'll just give you like 15, 20 seconds. Okay. So just hold on to your answers, and we'll revisit this a little bit toward the end of the presentation. So my talk today will be focused on structural competency, health equity, social responsibility, and it'll describe and expand on the article that I wrote here in academic medicine with colleagues at UCLA and also the Yale program. When I'm talking about structures today, the things that I mean are the institutional, the political, the social, and the economic forces, the upstream things that affect the social determinants of health and are at the root of health inequities. So I've structured this talk in 3 parts. First, I'll share with you what I've learned about homelessness as a structural problem. I'll describe relationships among structures, like state constitutions, racism, and our patients' health. And then second, I'll describe how some of those structures also affect our work as physicians, using some of the examples from my own work as a public psychiatrist. And then last, I'll share some of what we've been up to at UCLA, trying to teach structural awareness and action with our residents, and also to help us identify strategies that all of us can use to train ourselves to think, act, and to heal structurally. Okay, so when I often hear people ask me, how do people become homeless? And you can look to the person on the right. To answer that, people often, they look to individuals and they ask, what have they gone through? What illnesses have they experienced? What decisions have they made in their lives? But that's an individualistic view of homelessness. And so what I want to try to do today is to urge us to all look structurally. And so the first thing I hope that you take away from this talk is that homelessness is a structural problem. It's a problem of our American public safety net and macroeconomic forces that have been brewing for decades. Mental illness makes individuals more structurally vulnerable to the things you see there, like social isolation, housing, employment discrimination, criminalization. And those are major risk factors for homelessness. But I want to emphasize that there's nothing in the illness itself that causes homelessness, and nothing in the symptoms or the DSM criteria that causes homelessness. So I'll expand on this a little bit more as the talk goes on. So here we can take a look at some of the macroeconomic forces, the structures that cause homelessness. So on this graph, you can see the bottom blue line, which shows how renters' incomes have essentially flatlined since the 1960s, so nearly a 0% change. But the top line in purple shows how median gross rent has increased by 60% in that same time. And so the end result is that 1 in 3 US households are cost burdened. That means spending more than 30% of their annual income on housing. And if you look at only renters' households, so nearly 50% of renters are cost burdened. And being cost burdened is a major risk factor for homelessness. So housing is becoming more and more unaffordable and unattainable in America, and that's a major risk factor. Okay. So here on this slide, we're talking about the effects of this housing cost burden on spending. So the blue bars on the left are households without cost burdens. And then the purple bars on the right are households with severe cost burden. So they're spending more than 50% of their income on housing. And so what you see is that the more money that's spent on housing, the less is spent on even basic necessities like food, transportation, and healthcare. And so these are the tragic everyday choices that our patients and their families have to make. So here, you can see how scarce affordable housing is. So as a family's income decreases, housing that's available and affordable to them also decreases. And so that may sound common sense, but that's not the way that it necessarily has to be. And that's not how it should be, right? So Looking at the slide, so nationally on average, for every 100 people that make the area median income of their locality, there are 101 rental units available to them. So they have enough housing. But when you get to extremely low income, and that's less than or equal to 30% of the area median income, so in LA, that's $20,000 annually. For every 100 of them, there are only 35 units available to them that are affordable. Okay, so those are national numbers. What does it look like locally? It turns out in LA, and this will not come as a surprise to anyone on this, I'm sure, but we have one of the most severe housing shortages of any metropolitan area in the United States. So for every 100 renters making $20,000 annually in LA, there are only 17 affordable and available rental units. There's a myth also that people flock to LA to experience homelessness because the weather is so great and the services are so plentiful. But these graphics speak directly to that myth. And it shows that 65% of people who are homeless in LA have lived here for more than 20 years. And actually, the chart on the right shows that 75% of people experiencing homelessness became homeless in LA. So most people actually aren't moving to LA to be homeless. They're driven into homelessness by the economic forces that I was just talking about. So in sum, over 500,000 people in Los Angeles are severely cost burdened, meaning they're spending more than half their income on housing. LA needs more than 500,000 new affordable housing units just to keep up. Rents on the rise while income's actually decreasing. And LA County and California both have among the highest rates of poverty in the United States when taking into account the cost of living. And you'll notice that I haven't mentioned mental illness at all up to this point. So it's essential for me to highlight that these forces don't impact everyone uniformly. So I want to read this quote. 250 years of slavery, 90 years of Jim Crow, 60 years of separate but equal, 35 years of racist housing policy. Until we reckon with our compounding moral debts, America will never be whole. And that's from Ta-Nehisi Coates, The Case for Reparations. So this is a particularly powerful quote for me because it places racist housing policies alongside these monoliths of government-sponsored racism. So slavery, Jim Crow, separate but equal. And on that topic, I want to try to show you, if technology allows, this video. An ad may play, so we'll see how this goes.
Today, another federal program that was perhaps even more powerful in creating racial segregation, and that was a program of the Federal Housing Administration designed to move white families out of urban areas into single-family homes in the suburbs. At a racially explicit basis, we created a white noose around every urban area with federally subsidized single-family home subdivisions. These were giant subdivisions in many cases. The most famous of them, I'm sure you've heard of it, is Levittown, east of New York City. 17,000 homes in one place. What bank would be crazy enough to lend a developer the money to build 17,000 homes or 15,000 homes in one place for which he had no buyers? We were in a suburban country at that time. People thought the whole idea was lunacy. Who's going to want to live in a single-family home when they can live in the city instead? Any of these developers, the only way they could get the capital to build these giant subdivisions was by going to the Federal Housing Administration, submitting their plans for the development, for approval of the construction materials they were going to use, the architectural design, the layout of the streets in the subdivision, and an explicit commitment not to sell a home to an African American, required by the Federal Housing Administration. The Federal Housing Administration even required, as a condition of these guarantees, developers like Levitt to place a clause in the deed of every home prohibiting resale to African Americans or rental to African Americans. These deeds still exist in these homes today. They're no longer enforced, no longer enforceable, but they're still there.
This life-saving device stops a person from choking in seconds. Do you know
what was the consequence of this? Well, those homes in those days, in all of these suburbs, they sold for $10,000 or less, $8,000, $9,000 a piece. In today's money, that's less than $100,000, probably $90,000. African Americans who were prohibited, not that they didn't want to, not because they didn't like living among whites, they were prohibited from moving into these suburbs, and they could easily afford to do so. Any working class family can afford to buy a home for $90,000, roughly twice national median income. Those homes and developments like that now sell for $300,000, $400,000, $500,000 and more. The white families over the next couple of generations gained, you can do the arithmetic, $200,000, $300,000, $400,000, $500,000 in equity. They used that equity to send their children to college, to take care of medical emergencies, to take care of economic downturns, most importantly, to bequeath it to their children, who then had down payments for their own homes. African Americans who accumulated none of that wealth as a result of this federal subsidy had none of those abilities. Today, nationwide, African American incomes are on average about 60% of white incomes. African American wealth today is 10% of white wealth. That enormous disparity between a 60% income ratio and a 10% wealth ratio is entirely attributable to unconstitutional federal housing policy practiced in the mid-20th century that has never been remedied. It's a constitutional violation, and of course it determines the ongoing racial inequalities we have today.
Thank you so much for watching that video. I really wanted to share it with you. It's just such a vivid example of racism in housing policies. Sorry about the ad. It's so hard to follow up Richard Rothstein, but I wanted to show this graphic which speaks to his last point. So you can see home equity, that's the black bars on the left, and it remains the primary store of wealth for most Americans. And I think that's particularly important for lower income households. So the median wealth of low income homeowners is 81 times greater than the median wealth of renters with comparable incomes. Okay, 81 times greater. And so housing is such an important investment. It's described as the anchor or the foundation of American wealth and financial security. And as we just saw, there have been systematic attempts, that's just one of them, to strip home ownership and wealth away from people by race, particularly the Black community. So I want to recommend this article to you. It's from the 1619 Project, the New York Times. And it's something that I use in my teaching with our residents around homelessness. I'll briefly describe it. The article focuses on Mr. Elmore Bolling. He was a wealthy Black business owner and a family patriarch. He lived in Alabama in the early 20th century. He owned a general store, a gas station, catering business, a farm with cotton, corn, sugarcane. He had 40 employees. In today's dollars, he had an estimated $500,000 in cash and assets. In 1947, he was murdered by a group of white men. And so this is a story about how Black people have been systematically stripped of their wealth by the criminal justice system, banks, loan corporations, and inequitable laws, like they describe in this article, like the GI Bill. And so since the death of Mr. Bolling, none of his descendants have been able to achieve that same level of prosperity. And these are World War II era photos from FDR's executive order to relocate Japanese and Japanese Americans on the West Coast to internment camps. So Americans of Japanese descent, they were forced to leave their communities, sell their belongings, their businesses, often at unjust prices. So you can see the evacuation sale on the right. And much of that wealth was never regained. And much of the communities that were disbanded never reformed. And so these are stories about how Americans, this slide and the last one, they're stories about how Americans were stripped of their wealth, their lives, their freedoms, because of racist government policies. And this slide from the LA Homeless Services Authority brings this point home, that structural racism plays a huge part in homelessness. So in LA, Black people make up 33.7% of people experiencing homelessness, yet they're only 8% of the county population. And racial inequalities, I want to underscore, racial inequalities in housing aren't confined to housing. So they have ripple effects on inequities in taxation, school systems, and food deserts, as an example. So in sum, homelessness is a structural problem. It's one that's particularly harsh for Black and Brown communities. Mental illness makes someone more structurally vulnerable, but illness itself does not cause homelessness. And no level of mental health services will eradicate homelessness. And as I've tried to show, homelessness is just much more of a complicated problem than that. Okay, so this is part 2 of the talk. So we just talked about how structures affect people experiencing homelessness, but in this part of the talk, I want to describe how structures govern us as well when it comes to homelessness. So every year, on a night in January, cities across America count the number of people experiencing homelessness, both in shelters and in unsheltered locations. So some of you may volunteer for the San Francisco homeless count. So you can see the definitions of homelessness and unsheltered homelessness on the bottom there. If you could just take out a piece of paper, you can try to jot it down, or you can do it mentally, but try to fill in the remainder of this table. So you can see New York City, LA County have comparable numbers of people experiencing homelessness. These are huge numbers. What proportion of them are unsheltered? What proportion, how many are total unsheltered? I'll give you like 15 seconds or so. Okay, thanks so much for doing that. So these are the actual numbers. These stark numbers, they hint at a difference in context between the two cities. So New York, like I said, just has a similar population of people experiencing homelessness, but the numbers of unsheltered individuals are just orders of magnitude higher in LA. Okay, I'll talk about this more. So this is a photo that I took as a public psychiatry fellow at Columbia. This is a photo of the Queensbridge Bridge on the Upper East Side of Manhattan. And you can see here, there are these metal bars, and then there's this metal fencing. And in between the two, there's about 3 feet of space. And there's people sleeping head to toe about halfway down the bridge. Okay. So during my public psychiatry fellowship, I saw a man in his 50s. He had a primary psychotic disorder, PTSD, traumatic brain injury, alcohol use disorder, and was wheelchair bound. So I saw him several times on this bridge with our team to conduct my psychiatric evaluation. I also saw another man in another location. He was in his 50s with schizophrenia. He was living on a park bench along the East River. So what could I do as a psychiatrist to help them? And so I think to answer that question, I want us to think structurally, right? And to take a look at the New York State Constitution and Callahan v. Cary. So some of you may be familiar with this, but it's a class action lawsuit in 1979 brought against New York on behalf of Robert Callahan and residents of the Bowery on the Lower East Side. And that's a historical district where people using alcohol would gather and often experience terrible homelessness and social conditions. And so they sued the state to provide them with shelter. They cited the New York State Constitution, Article 17 on social welfare. You can see it there. And New York State Supreme Court agreed with them. And they said that their decision was, the court is of the opinion that the Bowery derelicts, that's what they called them at the time, are entitled to board and lodging. There is no reason why these homeless and indigent men cannot be lodged and fed at institutions wherever available in the state. And it's incumbent on those public officials caring for the needy to find such lodgings. And so this led to a consent decree that in New York City, people have a right to shelter. It's not perfect. It's not a right to housing, but it is a right to shelter. And this right was reinforced by subsequent lawsuits in the 80s and 90s, protecting the rights of women, families, and children to shelter. And you can see the downstream effects here. So since the 1980s, the numbers of shelter beds have risen in New York City. You can see 12,800 here to 63,000 in 2018. And this reflects two things, right? So this is the rise of homelessness in New York City, but it also illustrates the powerful animating effect of these court decisions to motivate the development of the nation's largest shelter system. And so returning to those two clinical cases that I mentioned, so what could I do? Luckily, there were structures in place. They're imperfect, but they exist. So in New York City, if you're experiencing homelessness, you're entitled to a place of shelter that very night. It's a whole system of shelter beds, and in the shelters, there's a pathway, a very extremely challenging one, but there's a pathway toward permanent housing, okay? But for some, including my patients, illness and other vulnerabilities make it impossible to navigate the shelter system. So for them in New York, there's this alternate pathway to housing called the NY3 Agreement. And this is the nation's largest system of permanent supportive housing. It's over 16,000 units. And so just to focus on this slide a little bit, so New York City organizes its homeless engagement into homeless outreach consortiums with one nonprofit organization managing the outreach for an entire borough. And they're tasked with identifying, engaging, enrolling, and supporting people in permanent supportive housing. And so to qualify, you must be chronically homeless, and you must also be part of an at-risk population. So there's this favoring in the system for the people that are most vulnerable experiencing homelessness. And that includes people with serious mental illness and people with substance use disorders. And so I had an opportunity as a physician to work on these teams. And these teams have these heroic social workers and case managers and peer specialists who do the incredibly hard job of engagement, 24 hours a day, actually. But once the clients are engaged in the process, the psychiatrists, so I had the opportunity to essentially write them a prescription for housing. It can be thought of as akin to what they're doing in the UK around social prescribing initiatives, where physicians have the opportunity to activate community resources for patients in great need. So both of my patients that I just talked about went from chronic unsheltered homelessness to permanent supportive housing. So my intentions to address their housing needs were supported by established structures, like a state constitution. So you had these policies and these public systems working together. Okay. So turning to LA. So in LA, both of these patients are in their 50s. The man on the left has a history of methamphetamine use disorder and a primary psychotic disorder. If you can't see him, I highlighted his foot here. The woman on the right has a history of schizoaffective disorder bipolar type and a history of over 40 psychiatric hospitalizations. So when I arrived in LA and I started working with our public mental health system, I thought that I could do what they did in New York. I could find an article in our state constitution. I could bring a class action lawsuit that would create not a right to shelter, but a right to housing. And that's what I wanted to do. But what I found was actually the exact opposite. And I found this legacy of racism that's built right into our state constitution. So in California, we have what's called Article 34. And I just want to emphasize this is just one part of the homelessness problem in our state, but it can be thought of as emblematic of the difference in structural forces that we have, and also this different culture that we have toward those most in need. So in the 1950s, California voters added Article 34 to our state constitution by referendum, with the explicit intent to give cities the power to block low-income housing developments. So the article reads that no low-rent housing project shall hereafter be developed, constructed, or acquired by any state public body until the majority of the qualified electors in a city, town, or county in which is proposed approve such project by voting in an election. So in other words, in order for low-income housing to be built, that locality would have to call an election and vote for it. So in 1968, the Federal Fair Housing Act was passed, which bans discrimination by race in housing. And then in 1971, Black and Latinx citizens of San Mateo County and the city of San Jose, they pushed forward a lawsuit to declare that Article 34 was unconstitutional and racist. And a California district court agreed with them. So then it went to the Supreme Court. Okay, and ultimately, Article 34 was upheld by the US Supreme Court 5-3. It essentially said that Article 34 wasn't discriminatory because it didn't mention race explicitly. It only mentioned income, and that discrimination by class is allowed. And so this has been called by historians as one of the most important defeats in civil rights history in the last century. That the Supreme Court effectively allowed a colorblind defense of a policy that de facto discriminated against Black and Latinx low-income populations. And so this is Thurgood Marshall, and he wrote the dissenting opinion. And so he says that the article explicitly singles out low-income persons to bear its burden. Publicly assisted housing developments designed to accommodate anyone else. So the aged, veterans, state incomes, persons of moderate income, or any class of citizens other than the poor need not be approved by prior referenda. He says, in my view, Article 34 in its face constitutes invidious or unjust discrimination, and he calls it discrimination between rich and poor. So Article 34 had many downstream effects. So locally in LA, one example is the Chavez Ravine community, where there were 2 planned housing developments that were canceled because Article 34 was in place. And it displaced a historically Mexican-American community. You can see the protests over there. And that eventually became the site of Dodger Stadium, you can see on the right. At the state level, between 1950 and 1969, nearly half of the public housing that was put forward in Article 34 elections were rejected. And more than that, there was also this chilling effect that Article 34 had, because localities, they withdrew housing proposals, or they didn't even put them forward, because there was a fear of triggering an Article 34 election, which was very costly, both financially and also politically. And then lastly, nationally, the Article 34, it halted this momentum that had actually been building toward integrating housing in American cities after the Fair Housing Act. So right after the ruling of the Supreme Court, Nixon released a statement about federal housing, and he said that a municipality that does not want federally assisted housing should not have it imposed from Washington. And he cited the court's decision on Article 34. And you can see those comments that I just read echoed in Donald Trump's tweet that you can see on the bottom right. And that's a tweet about his replacing of an Obama era fair housing protection. But there have been 3 subsequent attempts to repeal Article 34 in California, and all of them have been unsuccessful. And it's still on the books. And these are just some articles talking about the legacy of structural racism and classism built into our Constitution. So both of my patients, returning to them, they tragically remain unhoused. They're receiving intensive outreach services from the LA County Department of Mental Health. You know, we're working to try to get them into some form of residential treatment services, but all of those services are temporary. You know, they're not permanent supportive housing, like I had talked about before. So my takeaway from these experiences in New York and California is that policies and structures can be very powerful in creating opportunities or even incentives for physicians to address the root causes of suffering. So in this case, housing and homelessness. So in New York, I was able to prescribe permanent housing with services for my patients. And in the California example, you know, I haven't changed. You know, the things that I want to do for my patients are the same. My clinical teams, they're just as dedicated. And my patients have similar housing needs, but there are these detracting policies and systems that can frustrate my best efforts. Okay, so I just want to, before I go into the last part of our talk, I just want to take us back to that reflection exercise. Just take a quick second, think about that patient experiencing homelessness that you treated, that you had in mind before. And I just want to say, so structures can obstruct our best intentions as healthcare providers. What structures obstructed your efforts for your patient? And maybe name 1 or 2 steps that you'll take towards structural action. What can you commit to? I'll give you like 10, 15 seconds. Okay. Thank you so much for doing that. Thank you for committing to those structural actions. And to help fuel that conversation, that brainstorming, I want to launch into the last section of my presentation. So in the last section, I want us to focus on action, right? So I've done a lot of reflection, as I know many of you have. I know that there's the Structural Competency Working Group there and many others who are leaders in this. But I've done a lot of reflection and teaching on structural competency. And what I found personally is that as I train some residents to be more structurally aware, they can sometimes, some of them, they can feel actually more powerless and demoralized. And I think that that's because we start to realize, like you see on this slide, that the majority of health is determined not by healthcare, not by access or quality to healthcare, but actually by structural and social determinants of health. Yet we as physicians and healthcare providers, we're often trained to view our role as acting solely within healthcare settings. And so I think to evolve in structural awareness and to combat hopelessness, I think, we must re-envision our roles as healthcare providers, and I think for that we need new skills in thinking, acting, and healing structurally. Healing those laws, those institutions, those policies, those state constitutions that harm our patients and obstruct our efforts to address the needs that you see here on this line. Okay, so for that, I think that there are four things that are critical. First is understanding our local context. We don't practice in a vacuum, we practice locally. Second is that structural action begins with patient care. Third is physician advocacy, and then fourth is structural humility and partnering with community. Okay. So I'm going to highlight a little bit of our work with our energized resident and faculty group in Community Global Psychiatry. We call it CGP here. Our group was created by residents. I see Isabella on the presentation, but I've been fortunate to be a faculty lead for this group, and I hope you visit our website below. Okay. So we try, taking the first part, so we try to teach locally. Okay, so residents should know about local history, local challenges, local strengths, local culture. And when we teach about homelessness, we use a local redlining map like this one. And it describes how race is encoded into housing policy and mortgage assessments. And so this map was taken from this amazing resource by the University of Richmond. I hope you check it out. It shows the actual scans of the maps and the real appraisers' notes. But we try to connect that legacy of redlining to what's happening now, the local inequities that we're seeing during this pandemic in every city. And so this graph shows that COVID-19 infection rates by LA region have stark inequities. You see double the infection rate in South and Central LA, which are predominantly Latinx and Black communities. They're redline communities, compared to South Bay and the West Side, which are more highly resourced. We also teach that structural awareness and action, it begins with patient care. So I'm not advocating for you to talk to your patients about who you voted for in the election, but actually, like the cases that we explore today, you all have patient encounters like this every day that you can trace to laws and local policies that need to change. And those efforts, they need our voice as healthcare providers. And so these are articles from an event that we did with our residents on troubling trends that we were seeing in criminalization of homelessness. How in LA, they were taking steps to lock up people, to control encampments, rather than to offer them services. And so we're teaching our residents about local challenges and opportunities for reform. Okay, and this is a class that we do with our residents on how to help their patients navigate social benefits bureaucracies. And we frame things like SSI and the other services that you see here as structural interventions. So Ippolitas Kalafanos, Helena Hansen, they're both faculty at UCLA and in our center. And they've written extensively on this topic, and I co-teach a class with Dr. Kalafanos on this. So moving on to physician advocacy, these are some photos from advocacy events that we did on the topics of criminalization of homelessness, ending jail expansion in LA County, and then gun violence as a public health issue. These were all pre-pandemic, of course. But all of the events were done with community partners. I want to highlight that. And at our events, we use apps like 5Calls. I don't have any financial stake in them, but I hope you check them out because it helps us generate phone scripts and petition templates that we can use to contact our local lawmakers. And then we also use these educational events as opportunities to try to build connections with community-based organizations like Inner City Law Center. Okay, so writing in the lay press, it's also this amazing source of physician advocacy. And as healthcare providers, you all have stories and opinions that society values, right? So this is a piece written by our amazing residents and alumni. And it talks about the terrible weaponization of medical expertise against George Floyd in his autopsy. Okay, and then still on the topic of advocacy, we also teach that advocacy, it doesn't have it to happen in Sacramento or on Capitol Hill, but it can actually start within our own institutions and healthcare system. So I know that you all are active in this as well, but structures at our institutions, they need to change. And so, for example, we had a number of cases where police and sheriffs were pressuring our residents to discontinue involuntary holds for their patients, essentially so that the police could take them to jail faster, right? And so this policy change is an example of residents working together with faculty to ban law enforcement from trying to influence clinical care in any way. And I just want to pose that question: are there policies at your institution that could be reformed? And then lastly, it's absolutely essential that we do this work in partnership with community-based organizations and with structural humility. Physicians, healthcare providers, we can often get it wrong. And it's key to listen to the voice of community organizers, community leaders, nonprofit organizations that dedicate their lives to this work. And our goal is not to take up space, but ideally to lend our privileges and our expertise to policy change and social movements. So our residents and faculty, they were just a small part of just a much larger campaign to enact Measure J in LA, which dedicates county revenue for community investments and alternatives to incarceration. And that passed. And one of our residents in 2019 giving testimony at City Hall, or Board of Supervisors, sorry, in partnership with the organization Frontline Wellness Network, and it focused on ending jail expansion in LA. And so I'll just wrap up. So 3 takeaways from this talk. Homelessness is a structural problem with structures affecting our patients as well as affecting what we can do as physicians. And so to achieve health equity as healers, we must go outside of healthcare and act structurally, for our patients and for our local communities. And I'm going to end on this quote from Thurgood Marshall, from which I took the title. So he says, "We cannot play ostrich. In this chill climate in which we live, we must go against the prevailing wind. We must dissent from the indifference. We must dissent from the apathy. We must dissent from the fear, the hatred, and the mistrust. We must dissent from a nation that has buried its head in the sand, waiting in vain for the needs of its poor, its elderly, and its sick to disappear and just blow away. We must dissent because America can do better, because America has no choice but to do better." And then with that, I just wanted to share with you some resources, some books, and some podcasts. If you want to learn more about the topics that I was talking about today. I also shared my contact information there, and I hope you check out our article. It was in last month's issue of Academic Medicine. I included the citation on the bottom left. I'll leave this up on the screen for a couple of seconds, but thank you so much. It was a real honor to speak with you, and I'm looking forward to questions.
Thank you so much, Dr. Castillo, for speaking on this critical subject, and I'm looking forward to the discussion. So please, again, everyone, put your questions in the public chat. All right, so we'll get started here. The first question, someone's asking for us to provide the website again, so perhaps we can put that in the chat. And then next question, I'm aware of—
Here's the website here, on the bottom right. Thank you.
So the next question here is, I'm aware of Physicians for Social Responsibility and Physicians for Criminal Justice Reform. Is there an organization you can suggest that focuses on lobbying efforts related to the laws you mentioned, related to homelessness?
Yeah, that's a great question. So I think there's a lot of movement right now. I mean, honestly, I think that if you want to lend your physician voice to social causes, you should really look to organizations that you trust locally. So here locally, there's the organization Black Lives Matter, LA. The Black Lives Matter global organization was founded by Patrisse Cullors. And also they founded an organization in LA called Justice LA. And they're focused on criminal justice reform in LA County. And Justice LA has a number of offshoot organizations. One of them is Frontline Wellness Network that specifically focuses on organizing healthcare providers for public policy reform. So healthcare providers speaking to policies that have really nothing on their face to do with healthcare, but speak to the things that I talked about today. And so we really look to organizations like that, local organizations. I think that it's important to branch outside of physician-based organizations and look to communities. I mean, I'm sure that there's a number. That's one example that I'll give for LA. San Francisco has its own context, of course. But one last thing I'll say is that we first got connected with Frontline Wellness Network through the work of our faculty and then our trainees with that organization. And so if you're interested in partnering with organizations locally, try to reach out to your own faculty and your trainees because they're already doing that work. They've made those connections and relationships. And so you can try to expand that work and institutionalize it. So.
Thank you. So next question from Charles Furman. While mental illness is in a majority of cases may not be a primary driver of homelessness, are there instances you've seen when it might be? For example, one of our clients was evicted from supported housing 14 times for behaviors that appeared to be related to mental health issues. Another had $40,000 in the bank, but lived outside for a decade because they believed a higher power commanded them to. In these cases, we found mental health treatment helped resolve homelessness. What might you suggest as an alternative?
Yeah, I'm not denying that mental illness is a contributing factor. I think that I don't know the details of those cases. I think they're really important ones to bring up. I think what I would say is that in my experience, mental illness can be a factor, but I wonder if you could trace some of those symptoms as affecting more proximal things like social isolation or criminalization. Maybe they had experiences with justice involvement that further disadvantaged them. For example, people without those symptoms that you mentioned, they might have family, they might have other people, friends that they could draw on to, help them maintain some form of stable or unstable housing so that they wouldn't be unsheltered. So I just want to encourage that we think about, okay, if we're seeing mental illness playing out and someone experiencing homelessness, is it also affecting some of their other structural vulnerabilities as well? I think the other thing I would say is that we can imagine a different society where people experiencing those symptoms that you mentioned would be treated very differently and would have many more housing resources available to them. So for example, the cases that I talked about earlier, they had very severe symptoms, similar to the ones that you mentioned, but they were entering housing systems that specialize in working with people with serious mental illness or substance use disorders, which is very much unlike not all the housing in California. I can't speak to all, but like for some of it in California, someone uses substances and they're kicked out of that housing, or sobriety is a requirement. This isn't harm reduction housing like we would ideally want to see. Or also they're required to have mental health treatment to enter the housing. And if they stop their mental health treatment, they're kicked out of housing, rather than doing that work of engagement, which you see in other locales. So I agree with you. I think people with serious mental illness experience a ton of vulnerabilities. But two things. One is that the majority of people experiencing homelessness don't have mental illness or substance use disorders. And the second thing is that even for those who do, we can imagine a different society that treats them very differently. A lot of different resources that we just don't have available in California. It's a great question, though.
Thank you. I see someone has asked if you could share the Scientific American link, and someone, thank you, Allison, for sharing that. So that's in the chat. So next question, do you know of any organizations that support healthcare providers or others to write op-eds?
Yes. There's a larger organization that teaches people how to write op-eds. I think you can Google this. It's called OpEd Project. I know a number of our residents have worked with them. There's also a number of organizations that are dedicated to focusing on helping women and women physicians write op-eds. I know that a number of residents have participated in those as well. So OpEd Project is one. I've heard really amazing things about that organization, and I think you can hire them. Your institution can, to host a training for people there. But one thing that we did recently, I mean, Zoom is an incredible limiter, but also like this incredible asset. So, I mean, we started a new physician advocacy curriculum. It's started by one of our residents again. And we had 2 classes dedicated to writing op-eds and media advocacy. And so we were thinking, who would we want to teach that? And so we reached out to Richard Friedman, writes for the New York Times at Cornell. And so Zoom allowed us to have him teach that class. So There's also people at UCSF I know who write op-eds and are very active in media advocacy. So you can also bring them along to teach those classes. So those are just some examples. Yeah, I hope that answers that question.
Thank you. And I see a couple of other resources being shared in the chat as well.
Oh, great.
Next question, for the residents in the room, could you say a bit about your path to your current work?
Oh, sure. For me, minority health was incredibly important as soon as I entered med school. And so I was in med school, I threw myself into everything that I could do around minority health. When I entered residency, I knew I wanted to channel those experiences to public psychiatry. So public psychiatry, it's just this really well-established fellowship. You have this incredible fellowship at UCSF in that. But I knew about it in med school. I wanted to be a public psychiatrist. I thought public psychiatrists work with and bend these systems in ways that, I just love the kind of advocacy that they do. Like, for example, I think someone can have this incredible facility with psychodynamic psychotherapy or psychopharmacology. But then I saw these public psychiatrists have this incredible facility, kind of like an orchestra, conducting and like connecting their patients to community resources. So I did the public psych fellowship after my residency at Columbia. In public psych, I worked with Janie Medical, which is Project for Psychiatric Outreach to the Homeless, this incredible nonprofit where I took those photos that you saw. And I really started learning about homelessness. And then I knew that I wanted to, I had this lens on structures and advocacy and also research. And so I did a research fellowship after that, the National Clinician Scholars Program. And then, so I was able to bring kind of all my interests together. So like academic pursuits, kind of medical education, and then public psychiatry. And so that's what I do now. And so I work for the Center for Social Medicine. It's this really incredible supportive place for these ideas. But yeah, I think for me, it was just wanting to do work in the community. I do all of my clinical work field-based. It's all outreach-based, mostly in people's homes. But I think context is so important. And so I want to try to live that context out in my clinical work, in my teaching, in these presentations today. I think it's so important for physicians to be connected to just all the different things that affect our patients' lives, but are often stripped away in typical healthcare context.
All right. Damian Rose comments, I worry that DSM language can also be weaponized in unjust ways. I'm not sure if there's a question in there, but if you have any comments about the DSM and how that plays into your work.
Yeah, I know that you had a recent grand rounds on this topic. And so I think I would have to defer to that expert at UCSF on the DSM. I agree. I think it can be. I think medical expertise in general, like I mentioned before, so like there is that example in the Scientific American article where the residents, Dr. Crawford Roberts was the first author of that. So they very eloquently talk about structural gaslighting and how not just the DSM, but really all medical expertise has the potential to be weaponized in a way to disadvantage vulnerable populations. But on the flip side, you can look to Helena Hansen's literature. I'm thinking about an article that she wrote, Pathologizing Poverty, where medical expertise can be utilized to advocate for vulnerable populations. You can also see this in Hippolytus Kolofinos' New England Journal article on biological citizenship, where he talks about that same topic, which is that you can use medical expertise to help your patients, particularly with social services and benefits. It doesn't speak to your question particularly, but I think I'd refer you to the other Grand Round speaker.
Thank you. Christina Mangurian comments on the OpEd project and gives the link in the chat and mentions that the Center for Vulnerable Populations has worked with that organization and that they had an amazing training. Narrative Locke comments, do attendees here know organizations are looking at the UCSF Parnassus expansion that is currently being looked at by San Francisco Board of Supervisors? Housing for the UCSF community and percentage of low-income housing are issues on the table. So we go to Kevin K. What are the prospects for ending Article 34, especially at this time of a pandemic and increased awareness of structural racism?
Yeah, the prospects weren't good in the last election cycle. I think that there's always energy around these issues. I'm hoping that there's more movement around Article 34 in the future. That being said, people have found ways around Article 34. So you can build low-income housing and get around Article 34 by kind of like finding these loopholes. And so it doesn't affect as much of the low-income housing as it used to. But that being said, it needs to be taken off the books. I wish I could speak to the vicissitudes of Sacramento, but I can't. But yeah, I really hope that it's taken off. You know, sometimes the attention and is taken in different directions, and for important reasons. And so I think that there's a lot of things on the agenda. But yeah, it's something that I've prayed for and hoped for, and hope that I think that we can, like I said, lend our voices to community movements to show how damaging this is to our state.
Okay, and it looks like right now our last comment, Mark Smith shares that the Berkeley Media Studies Group has a media advocacy training for public health and healthcare folks and shares the link in the chat. So if there are no other questions or comments, that is the end of our chat. So I just want to thank you again, Dr. Castillo, and thank you all for joining us today at Grand Rounds.
Thank you so much. It's a big honor for me.
It was an honor for us.
Thank you all.
Thank you.